presentation mode. Okay, so I'm going to give an introduction to the grade approach to rating certainty of evidence, and in the context of clinical practice guidelines to rating the strength of recommendations. So I'm going to ask a little bit about whether you have your starting understanding of grade, provide some information about its background, grade's approach to rating certainty in estimates, in the certainty in the evidence and the estimates of effect. I'm going to introduce summary of findings tables, which are grade's way of presenting the summary of the evidence, moving then from evidence to recommendations and strength of recommendations. And we're going to go through a little exercise in applying grade, see how much you've learned. So I'm going to be asking lots of questions. Thank Liam has done a great job in preparing the polls, and thank you all for signing in with your computers to this presentation so that you can answer the polls. So the first poll is about your prior familiarity with grade, and the options are never heard of it until this talk, heard of it, but no idea what it's about, have a basic idea of what it's about, a good understanding of the basics, or you've actually used it in systematic reviews and guidelines. And so far, good. We have about, let's see here. Well, we're split across. One person never heard of it. One person heard of it, but no idea. At the moment, over 40%, just over 40% have a basic idea of what's it about, and another 35% good understanding of the basics. Now we're up to 3 people never heard of it. So if any of you are familiar with, if any of you are, and 3 people have used it in a systematic review and guideline. So if any of you are educators, you will recognize that we have a challenge. And then the group spans 3 people who've never heard of it till this talk, and 3 people who have been using it in systematic reviews with a majority of basic or good understanding of the basics. So it's a challenge now to meet the needs of those who've never heard of it, and at the same time meet the needs of those who've been using in systematic reviews and guidelines. The one way to deal with this challenge, I will try to be relatively simple, but at the same time, hopefully offer things that even those who have used it in systematic reviews and guidelines will learn something. So what I would like to do, and Susanna, you can help me, is any time that anybody has what I say is not clear, or there are doubts about it, please raise your hands. Susanna can help you, I'm sure, with your questions, and I'm ready to take questions. Be quite happy with interruptions. Okay, good. So thank you for answering that first question. So now, next question. Even those, there's a few people who've never heard about it, make a guess of what you think grade should be about. Is it about rating the quality of evidence for treatments, of diagnostic accuracy, diagnostic impact, that is, what is the effect when we give diagnostic strategy A or B on the outcomes that patients think are important, or it's about rating quality for prognosis? Which is it about? And you can have more than one choice. You don't have to restrict yourself to one choice here. All right, great. Okay. The most people treatment, a lot of people diagnostic impact. As it turns out, the anybody who said any of these is right, because grade started about rating the quality of the evidence for treatment interventions, but we subsequently found out that the grade approach works for all the others: accuracy, diagnostic impact, and prognosis. And there are papers out there about grade for each of those. However, this presentation will only focus on the first, which is the therapeutics, grade for what treatment should be using. Okay, next poll. Grade is about addressing the quality of individual studies, the quality of bodies of evidence, or both. Quicker people vote. We don't want to spend too much time just on voting. If you can come in quickly, then that would be great. I'll actually stop the poll. I won't let it go on too long so that we can keep moving. Okay. So at the moment, we have most people say it's about both individual studies and bodies of evidence. As it turns out, although grade has make suggestions about how the issues in individual studies, grade ratings are never about individual studies themselves. Grade ratings are always about the quality of evidence, of bodies of evidence. So it's always, there's a systematic review and you have all the evidence, and grade tells you about the quality of that evidence. Grade is also about rating different outcomes. For instance, you might have an anticoagulant, and it is about, you're going to rate your certainty or quality of evidence in both bleeding and stroke. Okay, what do you think? The certainty of evidence is always the same across outcomes. It's usually the same across outcomes, or it usually differs across outcomes. What do you think? Okay. And we're having between 70 and, well, now we're to under 70, but still the majority thinks it usually differs across outcomes. And that is correct. So very often, for instance, you will have randomized trials that look at the benefit outcomes, but you have some rare and unusual adverse outcomes that can only be assessed from observational studies. And so you'll only have low quality evidence about the adverse outcomes. So it's really quite typical to have some outcomes with higher quality evidence and some outcomes with lower quality evidence. All right, now a little bit of background about grade. When grade got started over 20 years ago now, there were a profusion of systems for rating certainty of evidence and strength of recommendations. Whole bunch available, and that odd stoplight gives a metaphor for the confusion that was created by all these systems. And grade came along as a way to try and address that confusion. So from the beginning, it was an international group of methodologists and guideline developers. The group has had around 50 meetings over the last 22 years. The meeting started in 2000, and by 2000, the group was ready to publish the first description of grade in the British Medical Journal. 4 years later, in 2008, a 6-part series in the BMJ that was for people, for clinicians who were consumers of systematic reviews and guidelines that use grade. Starting in 2010, and now a 34-part series and it was still growing, about how to use grade. And this was for the people who are making the grade ratings, the authors of systematic reviews, health technology assessment practitioners, and guideline developers. So you have papers for the BMJ papers for those who are reading systematic reviews and guidelines that use grade, and then this very detailed series of papers about the people who are using grade, who are making up the grade ratings of certainty of evidence and strength of recommendations. We're pretty happy with the uptake of grade. There's over 100 organizations, over 110 organizations worldwide that are using it, including very prominent ones like the World Health Organization, the American organizations, American Thoracic Society, American College of Physicians, probably the leading international use textbook, electronic textbook up to date, and the Cochrane collaboration. So very wide use of grade in prestigious and widely used systems. And that's part of the reason I'm very comfortable talking to you about it. Here is a little cartoon that has two people who are predicting the weather, what the weather is going to be like in the near future. And one of them is saying to the others, I figure there's a 40% chance of showers and a 10% chance we know what we're talking about. He's quite happy about it. His colleague isn't quite so sure. And what that emphasizes is the difference between predicting the likelihood of something and our confidence in that prediction. So here, if 40% chance of showers, we could substitute 40% chance that our guess is a 40% relative risk reduction in outcomes. But you really don't know what we're talking about. There's only very low certainty in our guess of a 40% relative risk reduction. So grade has two components. One is that first part that we just talked about, the quality or certainty or confidence that an effect lies in a particular, where an effect lies in relation to a threshold or range. I don't at the moment expect you to understand the second part of that. We're rating our certainty in something, but the effect lies in relation to a threshold or range. I expect that that is not clear at the moment. I will try to make it clear as we go along. And there's 4 ratings of certainty: high, moderate, low, and very low. Strength of recommendations, a simple 2 categories: strong recommendations and weak. Some organizations don't like to make weak recommendations. The World Health Organization will never make a weak recommendation. However, grade, it's because they don't like the term, they don't mind the concept. Grade offers alternatives: conditional, contingent, and discretionary. And grade, so the World Health Organization doesn't make weak recommendations, they make conditional recommendations, but it means exactly the same thing, a dichotomy between strong and weak. Okay, so randomized trials start as high certainty evidence. Observational studies start as low certainty evidence. You have 10 randomized trials. Things look good. But what might lower confidence, certainty, or quality? What might it be about these 10 randomized trials? Now, I asked Susanna, correct me if I'm wrong, Susanna, but I remember in our discussion that we could do something I've never done before, but do a buzz group for at a distance. So, Susanna, if you think we can still go ahead with this, we could ask our group to turn to those around them and spend 3 minutes, and each group hopefully will come up with something that we have 10 randomized trials. What might be the limitations of those trials? So it was looking good. Randomized trials started high certainty evidence, but why might they not stay at high certainty evidence? Shall we try it, Susanna?
Yes, I can divide them.
Okay.
O Gordon pediu para vocês, de repente, Gordon, I think I'll put participants in each table to do that together in groups?
Perfect.
Okay.
Whatever works in the setting that you are in, Susanna. Let's just give them a few minutes, and then you can help them. Maybe they can choose whatever language they like to each group to report back, and you can tell me what they say.
All right. O Gordon está pedindo para a gente, cada mesa, falar o que pode aumentar a qualidade da evidência, a certeza. Ele falou que tem 10 ensaios clínicos randomizados, né? Mas, assim, o que pode diminuir a certeza, a confiança de que aqueles estudos são de boa qualidade? O que pode diminuir essa certeza? Você tem uma seleção de 10 ensaios clínicos randomizados. O que pode fazer com que esses estudos tenham uma qualidade reduzida? Quais são os critérios? E para vocês discutirem isso em grupos, e depois a gente vai selecionar 1 ou 2 pessoas para poder falar. Isso pode ser voluntário, tá? Para reportar para ele. Pode ser em português, se for português eu traduzo, ou em inglês, diretamente com ele.
Qualificam mais ou não?
Gente, é melhor vocês escreverem o que vocês vão falar, tá? Ditem.
Okay, Susanna, should we try to get people's ideas?
Yes. Pessoal, o Gordon já está pronto para receber os inputs de vocês, da discussão de vocês. O que pode diminuir a confiança na qualidade, a confiança, a certeza ou a qualidade desses ensaios clínicos randomizados. Assim, olhar para ele e falar, olha, esses ensaios clínicos aqui têm problema. Por isso, por isso, por isso, por isso. Quais são os itens que vocês localizaram?
Vou tentar falar aqui que você me ajuda. We selected a couple of items here. Selection of the population, okay?
Okay,
Sorry.
so what would be a problem in selection of the population? We're thinking about problems in the RCTs. What would be a problem? What would constitute a problem in the selection of the population?
When we have different population compared between the groups, okay?
Okay, so, but this is a randomized trial we're talking about. So the whole purpose of randomization is to make sure that the people in the intervention group are very similar to the people in the control group. So, but sometimes randomized trials may fail to do that. So what would be problems? There is something called concealment of randomization, where the people enrolling patients do not know whether the next patient is going to go to treatment and control, and that would and they can manipulate the randomization, and randomization might not work the way it should. So you're absolutely right that if the randomization process has gone wrong, and the people in the intervention and control group have different categories in different characteristics, it's going to bias the results. So you're absolutely right that one problem that is going to lower your certainty of the evidence is risk of bias. If the randomized trial has not been well conducted, like lack of concealment, and randomization then fails to balance the groups with respect to prognosis, that's going to rate down our certainty if that happens in many of the eligible trials. Okay, so risk of bias is one problem that's going to lower our certainty. What's another?
Another one is about if the study is blinded or not blinded, single or double.
Right, excellent. So unblinded studies, just like lack of concealment, unblinded studies are liable to bias the results. So that's another example of risk of bias. And if studies are unconcealed and unblinded, we're liable to get biased results, and that is going to lower our confidence or certainty in the results. Excellent. What else?
The third item we selected is about the outcomes. If the study is analyzed per protocol or intention to treat.
Okay, excellent. The one way to ruin randomization is not to analyze people in the groups to which they were randomized. Randomization is useless if you don't analyze people in the groups that they are randomized. That is a third risk of bias issue. So you've identified three risk of bias issues: lack of concealment, lack of blinding, and loss and failure to conduct an intention to treat analysis. Okay, great. So risk of bias is one. Studies have high risk of bias. You're not going to get high quality or certainty evidence. Absolutely right. What else?
And
Any other
finally,
groups? Okay,
and,
your group.
and we
Good.
finally discussed about the relevance of the outcomes. Sometimes the methodology is okay, but the outcome is not applied to the context, okay, it's not relevant to that situation.
Great point. So let me give you an instance. We worry about surrogate outcomes. Say we're doing a study in diabetes, and what's measured is the glucose or the hemoglobin A1C. Well, what we're really interested in is trying to prevent the macro and microvascular complications. And the hemoglobin A1C provides some indirect evidence, but not very trustworthy. So that falls under another grade category, indirectness of evidence. We're measuring something that relates to what we're interested in, but is different. So we've identified risk of bias and indirectness of evidence as reasons to rate down. Any other suggestions? No other suggestions from your groups, Susanna? Susanna, do you hear me?
Yes, I'm just giving the microphone to someone here.
Okay.
Alex.
My name is Alex, and we would like to add the conflict of interest.
Okay, well, that's very interesting. So how is conflict of interest going to create a problem? Why would conflict of interest create a problem? How would conflict of interest?
If the research is funded or sponsored by a specific company that has a specific interest in the results.
Right, but how is that going to create? How is that going to create problems? How is that going to result in untrustworthy results? What's going to happen as a result of the company's interest in a particular?
Maybe if the researchers are paid by the company, they would be willing to give a result or release a result that would be in accordance with the interest of the company, maybe.
Do you mean they're going to make up data that isn't there? Is that what you mean?
Not make up, but not look like with no, how can I say? I'm lost.
What are they going to do?
It's going to be a selection bias. Yes, maybe could exist a selection bias on.
Okay, so great point. So that the problem can be that, for instance, they only tell us about the outcome that is good when there are other outcomes that they have measured that are not good. Okay, so a problem, and in a broader way with company studies, they might not even tell us about the study at all if it doesn't work out the way they want. So that will be a problem with publication bias. So you're right that we worry about industry funded, but particularly what we worry about is that they're not going to show us some of the data, either about particular outcomes or about publication bias. Excellent point. So we now have problems with risk of bias, we have problems with indirectness of the outcomes, and we have problems with publication bias. Great. Anything else that anybody has suggested?
Imprecision?
Yes, okay. Imprecision. Imprecision comes when there are a small number of patients or a small number of events and wide confidence intervals. Excellent. Okay, so we found a risk of bias, indirectness, imprecision, and publication bias. Super. Anything else? No other suggestions, Susanna, from your group?
People are talking about consistency of results.
Excellent. Okay. So if there's inconsistency of results, some studies have shown effect, other studies do not, and you can't explain that inconsistency, you lose confidence, certainty, or quality. Okay. You got all the major categories. So the major categories of problems that might lower the certainty of the evidence are risk of bias, inconsistency from study to study, indirectness, you identified indirectness of the outcomes, imprecision, small number of events, small number of patients, wide confidence intervals, and publication bias. Well done. Okay, so I'm going to talk briefly about each of these. You labeled lack of concealment, lack of blinding. You also labeled failure to do the intention to treat. Other risk of bias issues include loss of follow-up or stopping because you see a positive result tending to overestimate treatment effects. Now, I am going to talk about the issue of precision. And you might remember that I said we are rating our certainty that the truth lies on one side of a threshold or in a particular range. And I will demonstrate that with this slide. Look at the point estimate and the confidence interval, the first one at the top. You know, we may be, and there is the vertical line that is no effect, and the dotted line, which is the smallest important effect, because effects can be present, but they can be too small to be important. And here, the point estimate and the confidence interval show a bigger effect than null, clearly, because the whole confidence interval is to the left of the null. Not only that, but the whole confidence interval is to the left of the important difference. So we are, as far as precision is concerned, we're sure that there's an effect, and we're sure that it's an important effect. So here we are not going to rate down for imprecision. What about the second one? The second one, if we are rating our certainty in a non-zero effect, the entire confidence interval is to the left of the zero line, no problems with imprecision. However, if we are rating our certainty in an important difference, the point estimate and the upper boundary of the confidence interval are to the left, are bigger than the minimally important difference. The one to the right, however, the confidence interval, the lowest boundary, is less than the minimally important difference. Here, we have a problem with imprecision with respect to whether the truth is larger or smaller than the minimally important difference, and we're going to rate down for imprecision. What about the third one? The third one, if the confidence interval overlaps no effect, there is some of it is on the harm side, some of it is in the benefit side. Well, we're not so sure about whether there's an effect or there isn't. It crosses our threshold, and we'll rate down for imprecision. However, if we are rating our certainty in a minimally important difference, the entire confidence interval is to the right of the minimally important difference. We don't have any doubts there. We don't have any precision. As far as the precision is concerned, we are confident that the effect is less than a minimally important difference. And the final one, the confidence interval crosses both thresholds, and whether we're rating our certainty in no effect or we're rating our certainty in a small but important difference, we're going to be rating down for imprecision. So the bottom line is, when people use grade, they should be saying, what are we rating our certainty in? Are we rating our certainty that there's a non-zero effect? Or are we rating our certainty that there's an important effect? And if the confidence interval, whichever one you're rating, if the confidence interval is all on one side of your threshold, you won't rate down for imprecision. But if it crosses the threshold, you will rate down for imprecision. I'm going to stop here for a second. Susanna, look around. Anybody, is that clear to folks? Or anybody have any questions about that concept? It's a very important concept for grade.
Alguma questão, gente, a respeito do que vocês acabaram de ouvir aqui do Gordon? Está claro para todo mundo o que é essa diferença mínima que importa? Aquela linha tracejada ali. Vocês estão vendo que o intervalo de confiança, ele atravessa a linha tracejada apenas na segunda e na quarta posição ali. Né? Está claro o que isso significa? Está claro o que significa o intervalo de confiança para o lado direito, né? E não passar pela linha tracejada, e do outro, do lado esquerdo, completamente do lado esquerdo. Convencionalmente, por convenção, Aquela terceira situação ali significa que do lado de cá ele está favorecendo o tratamento. Quando ele está todo do lado de lá, ele está favorecendo o outro grupo, o controle, né? E no caso da diferença mínima que importa, que é a diferença clínica, o que a gente considera clinicamente significativo? A linha contínua é uma linha de efeito estatístico. A tracejada é uma linha de efeito clínico, que a gente pode chegar a ela simplesmente por convenção, né? E decidir o que é a linha, o que eu aceito como efeito clínico. E, a partir dali, saber se aquela diferença ela é significativa ou não entre um grupo e outro. Está claro? Gordon, I just rephrased what you
Yes,
said
that's good.
using
I'm
my
glad.
words.
I'm
And
very glad you did that.
Apparently,
Yeah,
people,
it's a,
they have no questions so far.
okay, good. We'll keep going then.
All
Okay,
right.
the next thing we're going to deal with is consistency. So, Liam, I don't remember where all of the, I might forget where all the polls are. If I'm going to miss a poll, please speak up. So I think there might be, is there
We
a
have a
poll
poll
with this
here.
one? There
Yeah.
is, right?
Yes.
Okay, so here are results. There are 4 results, point estimates of 0.73, 0.74, 0.76, and 0.71 in terms of relative risk. And then you have the pooled estimate. And what's our question, Liam? Are you worried about inconsistency? Yes, okay. So are we worried about inconsistency? Yes, we're worried about inconsistency, and we might want to rate down for inconsistency. Or no, we're not worried about inconsistency.
Pessoal, naquela situação ali, vocês ficam preocupados com inconsistência dos resultados ou não? Para responder essa pergunta.
So at the moment, the majority are worried about inconsistency. Splitting about 60-40, worried about inconsistency. All right, let's stop the poll. And 60-40 worried. Can somebody tell me, among the majority who are worried about inconsistency, why are you worried about inconsistency of these results? Can somebody explain to me?
Gente, quem respondeu que está preocupado com inconsistência, ele queria que falasse, comentasse por que está preocupado com inconsistência. Fala no microfone.
I'm worried about it because half our studies can't say for sure that it favors intervention or outcome. I don't know which side you put in.
Right, so 2 of the 4 studies overlap no effect, okay?
Yeah.
But the whole reason we do meta-analysis is because we expect individual studies to be imprecise, and we expect that individual studies will have too small sample sizes and be imprecise. And that's why we pooled them together and end up with a pooled estimate that combines across the studies and as a result gains with precision. Okay, so one reason that you might have been worried about inconsistency is you say some studies seem to show a convincing effect and others do not. However, the most plausible reason for the studies that failed to show an effect is too small sample size. And as a result, they'll have wider confidence intervals. That's exactly what you expect when the studies are too small. And that's in the reason that we do systematic reviews and meta-analysis. Is for those who said that they were worried about inconsistency, is there any other reason that anybody was worried other than that the confidence intervals in 2 of the studies overlapped no effect? Any other reason?
Alguma outra razão que vocês gostariam de falar, gente? Por que vocês acham que os estudos são inconsistentes?
Okay, if no other reason, so is there somebody speaking up?
No,
If,
you can
if
go
not,
ahead.
if not, what grade means by inconsistency, you should look at the point estimates. How similar is 0.73 to 0.74 to 0.76 to 0.71? Very similar, okay? So grade would say, because the results of each study are very similar to one another, we don't have problems with inconsistency. And as I said earlier, the fact that some confidence intervals cross no effect and others do not is probably a function of the sample size. The bigger studies give narrower confidence intervals, the less big studies give wider confidence intervals, but the point estimates are very similar here. And so grade would say we don't have problems with inconsistency. What about this? Here's another result with a very similar pooled estimate and confidence interval. Do you have problems with inconsistency here? Who would say yes, we have problems with inconsistency here, and who would say no? Okay, here we are so far, about 90% of the people are saying we have problems. Not quite 90% anymore, down to about 86%. Most people say we have problems with inconsistency. And in this case, most people are right. Two of the studies here show big treatment effects. The top two show big treatment effects. The bottom two suggest harm, right? 0.44 represents about a 55% relative risk reduction, as does 0.5, where the 1.25 and 1.17 suggest increases in bad events. So some studies are saying big benefit, and other studies are saying possibly harm. So very, very different messages coming from the two studies at the top and coming from the two studies at the bottom. Two studies at the top suggest it works. In fact, it's a big treatment effect. Studies in the bottom suggest, if anything, that it might be harmful. Very different messages, and we say inconsistent results. So now I have slides. Here we are. Okay, so how did we decide that this one ultimately was consistent and this one was inconsistent? And we have two criteria for deciding. One is similarity of the point estimates. So here the point estimates are very similar. Here they are very different. And the other is overlap of the confidence intervals. Here, the confidence intervals are all widely overlapping, no problem. Here, not only are the point estimates different, but the confidence intervals on the first two studies don't even overlap with the confidence intervals of the last two studies. So those are our two criteria: similarity of the point estimates and overlap of the confidence intervals. And there's also another criterion, which is a statistical one that we call the I-squared. If the I-squared is 0, we are not worried about inconsistency. As the I-squared gets bigger and bigger, we are more and more concerned about inconsistency. So I-squared of 0, no worries. As the I-squared gets bigger, more and more worries. Anybody care to guess? Do we have this as a poll, Liam?
No.
No. Okay, good. Anybody want to guess? Anybody want to take a guess at what the I-squared is here?
Gente, alguém quer chutar qual é o I quadrado aqui dessa imagem, dessa revisão?
So remember, 0, we have no worries. As the I-squared gets bigger and bigger and bigger, we have more worries. Anybody want to guess what the I-squared might be here?
Quanto maior o I quadrado, mais longe estão os estudos uns dos outros. Quanto baixo? Someone here is saying that it is low, close to zero.
Absolutely right. And in fact, it is zero. These results are very consistent from study to study. And if you look at the I-squared, it will be zero. Anybody want to take a guess at what the I-squared might be here?
Hi.
Hi, right, you got it. And the I-squared is 89%. So the I-squared, we look at this the similarity of the point estimates, the extent of overlap in the confidence intervals, and the I-squared can also help us judge with the degree of inconsistency. So variation in side effect, overlap of confidence intervals, and the I-squared. Okay, the next issue, the great concern is indirectness. Okay, we may be interested in younger people, but the studies may have older people, or more or less the opposite. I mentioned I was a little late here because I got caught up in my clinical practice. I do inpatient internal medicine, and a lot of my patients these days, or quite a few, are over 90. I try to base my treatment on randomized trials, but I'm a little hesitant about applying those trial results to people over 90 because very few were in the studies were over 90. There's a treatment called endarterectomy for people with carotid artery disease. And there was a trial that showed in people with asymptomatic coronary artery disease, sorry, not coronary artery disease, carotid artery disease, carotid artery giving blood to the brain. And the trial showed an apparent benefit with endarterectomy, but nobody applies that. The reason they don't is that the surgeons they chose for the trial had to show extremely low rates of complications from their endarterectomies, much lower than typical surgeons. So the study showed that the endarterectomy worked in the hands of these elite surgeons. That's only indirect evidence for typical surgeons, and that's why people don't use it. Comparators may be different. Standard care, we may be comparing to standard care, but if the study was done in Canada and you're applying it in Brazil, standard care may be different. And finally, indirectness of the outcomes. That's one you already got. Remember the diabetes example that we may be measuring glucose or hemoglobin A1C, but what we're really interested in is macro and microvascular complications. So indirectness is another issue. And finally, you mentioned publication bias. If the trials are being done by industry, they may be hiding things. And we particularly worry about publication bias when there's a number of small studies that are industry sponsored. Okay, what is another clue about possible publication bias? This is something called a funnel plot. On the x-axis is the precision of the estimate, narrow confidence intervals if it's precise, wide confidence intervals if it's not precise. That's on the y-axis. On the x-axis is the magnitude of the effect. We'll say to the left there's large effects, and to the right there are small effects or even possibly harm. If the studies are all unbiased, the large studies at the top here will be precise estimates near the truth. Unbiased, large sample size, near the truth. Smaller studies will still be unbiased, so they will be symmetrically distributed around the truth, but because of their small sample size and random error, individual studies might be far from the truth in one direction or the other. And if you go to the smallest studies, if they're unbiased, again, they will be symmetrically distributed around the truth, but individual studies, because of random error with the small sample size, may be far from the truth. And with a little imagination, you can say this looks like an inverted funnel, and that's why they call it a funnel plot. Here's another funnel plot. And now the question is, like the children's game, what's different between this picture and this picture? Okay, have a look at this one again. Have a look at this one again. What is the difference between this picture and this picture? Anybody see a difference?
Alguém gostaria de falar qual é a diferença entre uma figura e outra, gente? O que vocês estão enxergando ali? Se quiserem mencionar, eu posso traduzir, se vocês não quiserem falar diretamente em inglês. Qual é a diferença de uma figura para outra? O que vocês estão enxergando ali? A figura mesmo, a imagem. Fala aí, explica. Ou você quer que eu explique?
Any suggestions, Susanna?
Yes, you have less studies than the previous one favoring control, with outcome measures favoring it. High
Okay,
outcome.
perfect. So you can see here, it's the smaller studies are symmetrical around the estimates from the large studies. Here, there's a missing quadrant. You have studies over here that are bigger than the effect in the large studies, but no parallel ones over here. And this is a clue of publication bias. We think publication bias is more likely to happen in small studies. And if you see small studies that favor the intervention, but no parallel small studies on the other side of the effects from the big studies, and that is a suggestion of publication bias. Very good. Okay. So what we found so far is randomized trial starters high quality evidence, but there's lots of reasons they may not end up with high quality evidence. Could it ever go the other way? Observational studies start as low quality evidence, but they end up as high quality evidence. Answer is not very often, but it does happen. So when everybody used to do badly and almost everybody does well, and it happens quickly, we don't need randomized trials. For instance, insulin for diabetic ketoacidosis, no randomized trials, but because people with diabetic ketoacidosis get better so quickly and dramatically with insulin, and before the days of insulin, they often died, we believe that insulin is effective, and we're convinced it is. Patients who have bad osteoarthritis and you replace their hips, they get better very quickly and dramatically, and what was an inevitable downhill course is reversed. And finally, another extreme example, it used to be that when your heart stopped beating, you were dead. Not anymore. If you're in the right setting, you may be resuscitated from your cardiac arrest. We don't need randomized trials to when 100% of the people would have died, and now some people have survived. We know that that's an effective treatment. So large effects that happen quickly may give high certainty evidence. So here is summarizing what we have said so far about GRADE. Randomized trials start as high certainty or quality evidence, but if they have problems with risk of bias, inconsistent results, indirectness, imprecision, or publication bias, they may go to moderate, low, or even if they have problems in all these areas, to very low. Observational studies start as low, but if you have a large or very large effect, it may rate up to moderate or high certainty evidence. And the next thing I wanted to show you is what we call a summary of findings table. Whoops. Sorry. There we go. A summary. I just want to move this down so you can see a summary of findings table that tells, let's look at the first row. it's mortality. And in what we're comparing here is patients with COVID who are severe or critically ill, and you give them an immune modulator, an IL-6 inhibitor, and you compare it to standard of care. Well, as it turns out, there's a 14%, that's the 0.86, relative risk reduction in mortality with IL-6 inhibitors from a 21 to 5% reduction, relative odds reduction. You turn that into an absolute effect. 130 people will die if they are given standard care. With an IL-6 inhibitor, it will be reduced to 114, 16 fewer per thousand, confidence interval 24 to 6. In this case, high certainty evidence that IL-6 inhibitors reduce mortality. So this is grade summary of findings tables where you have, it says what the outcome is, what the relative effect is, what the absolute effect is, the certainty of the evidence, and a simple narrative statement. So we've now talked all about grade and the evidence summary. Now we're going to go from the evidence to the recommendations. So a strong recommendation is when the benefits clearly outweigh the downsides, the risk, hassle, and cost, or vice versa. Anybody want to suggest what may downgrade the strength of the evidence from the strength of the recommendation from a strong recommendation to a weak recommendation? Weak, or I've told you before, some people don't, some guideline panels like the World Health Organization doesn't like to say weak and they say conditional, but we either have strong or weak or conditional. What can move you down from a strong to a weak recommendation? Anybody have a suggestion? Susanna, tell me if anybody has a suggestion about what would turn a strong recommendation into a weak recommendation.
Com base nisso daí, o que pode transformar uma recomendação forte em fraca? Quais são os itens que vocês pensariam em relação a isso?
No thoughts? All right. There are two things. One,
É de ser too expensive.
Too expensive. Okay, good. Okay. So that might turn a strong recommendation to a weak because it is too expensive. Excellent. Any other idea?
Alguma outra, gente?
Okay, if not, let me suggest when the evidence is very low quality or certainty, we're uncertain about the benefits or we are uncertain about the downsides. If we are uncertain about the benefits and downsides, we can't say that the benefits clearly outweigh the downsides or vice versa. We don't know about the benefits. We don't know about the risks and hassles and costs. Then how could we possibly make a strong recommendation? So low or very low quality evidence will move from a strong to a weak recommendation. And the second thing, if the benefits and harms are closely balanced, the benefits and harms, and the example that you gave of high costs is an example of it being closely balanced. We may have the benefits are pretty good, harms are some of the problem, but part of the downsides is the cost, and that may move us from a strong to a weak recommendation. Susanna, you were going to say something? No?
Yes, like I think we missed most of what you said
How come?
at this last minute.
You mean
When you were explaining about the recommendation,
you mean
what
something
you
went wrong with
can
the
use
something went wrong with the internet?
the internet. Yes,
Okay. You hear me now?
yes. Could you
Okay.
repeat, please?
I certainly can. Okay. So one thing that might move from a strong to a weak recommendation is if we have low or very low quality evidence, because we make a strong recommendations when the benefits clearly outweigh the downsides. If we aren't sure about the benefits, only low quality evidence, or we aren't sure about the downsides, only low quality evidence, how can we possibly say that the benefits clearly outweigh the downsides when we aren't sure about the benefits and we aren't sure about the downsides? So one reason to rate down of a strong to a weak recommendation is uncertainty, low quality evidence. The other is if there's a very close balance between the desirable and undesirable outcomes. And one of the reasons there can be a close balance, you pointed out, is high cost. Maybe the benefits look pretty good. Harms aren't too bad, but it's a very high cost intervention, which makes it a close call between the desirable and undesirable outcomes. So those are the two reasons we can go from a strong to a weak recommendation is when there's only low quality evidence or when there's a close balance between the desirable and undesirable outcomes. Okay, so we like this approach that GRADE offers of strong or weak recommendations. And the reason we like it is that it gives real guidance to the clinicians. Let's move that up here. So we decide when there's a strong or a weak recommendation. What we think of is what patients who are fully informed, what they would choose. So if every fully informed patient or almost everybody would make the same recommendation, then we would make the same choice, we would give a strong recommendation. If patients would choose differently, some patients would say yes, some patients would say no, because of differences in their values and preferences, we are going to make a weak recommendation. And there are implications. I think I've done something wrong here because it isn't changing and I got this pencil that I don't like. I'm going to, whoops. I was going to get out. Okay, who is talented with computers? Anybody want to help me of what I can do here?
How about you stop sharing and try to share again?
Okay, thank you very much.
Thank you,
Liam, that is a great idea. Now, if I could only get out of this screen. Oh, where's the stop sharing? Let's see here. Stop sharing. There we are. Okay, good. Okay, and we will try again. Thank you, Liam. And I will go back here. And now we are okay. Liam, you're a genius. Thank you. That's why I have Liam here. If I can run into trouble. Thank you. Okay. The variability. So and the stronger or a weak recommendation has implications for interaction with the patient. A strong recommendation, you know, if you went through a shared decision-making exercise, everybody or almost everybody would make the same choice. So you can just tell the patient, here's what I think you should do, and here is why. A weak recommendation, people are going to make different choices if fully informed, and that argues for a full shared decision-making exercise. Decision aids are ways to help with shared decision-making, probably not necessary with a strong recommendation, necessary with a weak recommendation. And finally, quality of care. We're interested in measuring quality of care, but really the only candidate for a quality of care criterion is a strong recommendation, because a weak recommendation, the right thing to do will differ from patient to patient. Now, Susanna, I had an exercise in applying grade ready here, but I think I've taken quite a bit of time, and I'm wondering if I have time to go through that exercise. What do you think?
Let me ask people here. Vocês ainda conseguem ficar aqui mais um pouquinho? Porque ele ainda tem mais um exercício para fazer. Como é que está aí a paciência de vocês, a fome? People want to go on, Peter, Gordon.
With
I'm
the
sorry.
exercise, okay. Okay, I'm going to give an example of applying grade, and I'm afraid it's not a very glamorous example. The example is using venotonic agents for patients with hemorrhoids, okay? Now, these are supposed to increase the venous return. They're very popular in France. There's 90 of these venotonics commercialized in France, none in Sweden and Norway. France has 70% of the world market. I don't know what the situation is in Brazil, but it looks like there are two possibilities. Number one, the French are misguided. They're using a useless treatment, or the rest of the world is missing out. So what is it? The French are misguided, or the rest of the world is missing out about treatments for hemorrhoids? Well, as it turns out, we did I missed it. You've got to stop me. Let's see. Oh, yes. Okay. Thank you. Thank you. Okay. So is France right? Let's stop the poll. I've got to give more information before we run the poll. Okay. So I can stop it and we can do it again in a minute. Is that right, Liam?
Yeah, sure.
Okay, I'm going to stop. So after so thank you. Thanks for reminding me there's a poll here, but I've got to give some information before we run the poll. Okay, 14 randomized trials over 1,400 patients. The key outcome is the risk of not improving or having persistent symptoms. We found 11 studies with over 1,000 patients and 375 events, the events being the failure to improve. The venotonic agents, a relative risk of 0.4, a 60% relative risk reduction with a nice confidence interval from a 0.29 relative risk, that's a 71% relative risk reduction, to a point estimate of a relative risk of 0.57, that's a 43% relative risk reduction. And these venotonics have minimal side effects. With that information, now we'll run the poll. Knowing this, is France right? And the possibilities are, yes, French are right to use these venotonics. No, the French are not right. Or we need more information. We're not sure yet. What do you think?
A questão é, a França está correta em não usar flavonoides para hemorroida? Essa é a grande pergunta. E o resultado é aquele dali, o risco relativo de 0,4, com intervalo de confiança que vai de 0,20 alguma coisa até 0,57.
So far, we have half the people saying, yes, the French are right. And we have one person saying, nah, the French are wrong. And we have about half the people saying that we're not sure yet. Anybody else want to weigh in? So of those 14 people who have suggested, we now have 7 who say, yes, the French are right. We have 2 say, nah, the French are wrong. And we have 8 who are not sure yet. Okay, let me ask the 8 people, why are you not sure yet? Looks like there's a big effect here, okay? The people who, the eight people said they weren't sure. Why not? What additional information do you want? I'm even ready to let people talk for a minute with one another. I want to know these 8 people who are not sure yet, why not? What additional information do you want?
Por que não? Agora eu vou ter que falar. O que levou vocês a falar não? Quem falou não?
No suggestions, Susanna?
Not so far.
Okay, let me give you a clue. Remember, we have randomized trials. Remember the reasons why randomized trials may not give us high quality evidence. Have I told you about all that information? Are there any of the domains that may lower your certainty in evidence that I haven't told you about? And if so, what are they? Remember, you were very good. You identified our 5 domains. What haven't I told you about of the reasons why randomized trials may not lead to high certainty evidence? Can anybody remember what those are? And are there any that I haven't told you about?
Vocês lembram dos critérios que ele falou do grade? De consistência dos resultados, a questão da evidência direta, viés de publicação. O que ficou faltando ali nas informações que ele deu? A gente tem a precisão, a gente tem o intervalo de confiança, o que não tem ali? Hã? They said that you have the precision of the results, but you don't
Yes.
have all the rest.
Right. Okay. Very good. So now, now I'm going to be cruel. We have the precision of the results. You've got it, but we don't have all the rest. Who remembers what all the rest are? What don't we have? So that's the right answer. I've given you precision, but not all the rest. So, but what are all the rest? Who remembers?
Qual é o resto, gente? O que é o resto? Inconsistence.
Right? We haven't.
Or
Yeah,
consistency of results.
Sorry?
What else? Consistency of results.
Yes.
That is not in there.
That's one. What else?
Publication bias.
Right. We haven't addressed publication bias. What else?
What else? Huh? Okay. Esqueci risco de viagem em inglês. Risk of bias.
Good. Risk of bias. And who remembers the last one? So we've got, you identified, I've told you about the precision. Haven't told you about the...
Someone told indirectness.
Perfect. We got them all. Okay. So the reason why it was when I put up the poll, the right answer was we're not sure yet, because I hadn't told you about risk of bias. We hadn't considered inconsistency. We hadn't considered indirectness, and we hadn't considered publication bias. So to decide if the French are right or not, we need to look at these others. So any risk of bias problems, lack of detail about concealment of the randomized trials, questionnaires weren't validated. The questionnaires look quite reasonable. They say, are you still bleeding? Are you still in pain? But they don't have formal validation. Indirectness, probably no problem, unless you believe that French hemorrhoids are different from hemorrhoids in people in the rest of the world. Probably hemorrhoids are the same the world around. So probably not indirectness. Inconsistency, we need to look at the results. And here are the results. Almost all the studies but one have point estimates favoring the intervention. Only one has a point estimate that doesn't favor the intervention. And many of them have statistically significant effects. The point estimates, the confidence intervals don't overlap, no effect. However, some of the studies show big effects and some of the studies show much smaller effects. And that leads to an I-squared of 65%, a high I-squared, not because of inconsistency about effect, no effect. Almost all the studies show an effect, but some studies show bigger effects and some studies show smaller effects. Size of the studies, 40 to 234 patients, most around 100, all sponsored by the makers of flavonoids. And here is our funnel plot, perhaps there's a couple, there's three smaller studies are on the left side of where the big studies are showing bigger effects than, so maybe a suggestion from the funnel plot of possible publication bias. Okay, so here we are. Risk of bias, lack of detail about concealment, questionnaires not validated. I think we have a poll here about you want to rate down for risk of bias. Should we rate down for risk of bias? Yes or no? Who would rate down for risk of bias and who would not?
Quem tiraria pontos da evidência por conta de risco de viés? Marcar sim ou não, se você tiraria ou não pontos da evidência por risco de viés. Lembra que ele falou ali que tem um problema no cegamento do estudo, né? Lack of concealment. Tem algumas questões ali, os questionários utilizados nesses estudos não eram validados.
Okay, so far, everybody wants to rate down for risk of bias. Okay, let's end that poll. What about inconsistency? Almost all the studies, all but one, show a positive effect, with significant much of the time, but some show a bigger effect, some show a smaller effect, and the I-squared is 65%. Should we rate down for inconsistency? Yes or no? So we need to start with the poll again. I still see, is this the new, I see 13 out of 13 rating down, but is that the risk of bias or is this the new poll? Liam?
Está aparecendo para vocês?
Liam, you there?
There is some delay in the pool.
Okay.
This is, yeah,
Okay, it's a new poll, is it?
no, this
Okay.
is,
It's the old poll. Could we give
Yeah.
a new poll with a yes or no? Can we do that or not?
okay.
Okay, good. Okay, so now we're going for inconsistency. Who would rate down and who would not? All the studies are on all but one on the positive end, but some have bigger and smaller effects, and the I-squared is 65%. Who would rate down and who wouldn't? So far, we have about 2/3 rating down and 1/3 not rating down. Anybody else want to comment?
Alguém gostaria de comentar?
Yeah, it's about 2/3. 2/3 would rate down and 1/3 would not. Okay, good. That's fine. Now, the message here is, by the way, grade doesn't mean that we're always going to agree, because there's going to be close calls. And I would say this one is a close call. So the great advantage of grade is not that we're always going to agree, but that we have explicit and transparent criteria for our judgments. Okay, good. Now, Liam, I think indirectness, we're okay. Imprecision, we're okay. What about publication bias? If we could do that, yes, no, Paul, good, excellent, Liam, we've got an empty one. Who would rate down for publication bias? Yes or no?
Quem tiraria pontos da qualidade da evidência por conta de viés de publicação? Marcar sim ou não?
Okay, almost everybody, not everybody, but almost everybody would rate down for publication bias. Very good. Okay, so everybody who offered an opinion would rate down for risk of bias. There was disagreement about rating down for inconsistency, but almost everybody who volunteered would rate down for publication bias. Liam, do we have a poll about the overall certainty of evidence?
Yes.
Good. Okay. So now, given that we've addressed each of the domains, now this one, do we have one that has options high, moderate, low, or very low certainty?
Oh, no.
Okay. All right. Okay, that's all right. Okay. So if we were really going to rate down for all of risk of bias, inconsistency, and publication bias, we would have very low certainty. It would go from high to moderate to low to very low. If we were to rate down for two of them, we would have low certainty evidence. Okay, so it looks like we've got low, no better than low. This group thinks we have no better than low quality evidence, maybe even very low. Okay, now with that, are we going to recommend in favor or against the flavonoids? Okay, who would say yes, we should recommend in favor? Who would say no? Okay, we're splitting. So far, majority are saying no. About 20% so far are saying yes. Okay, so about 20% yes, only 15. Most people are coming down no. Okay, we're about 85 to 15. Okay, so not a lot of sympathy for hemorrhoid sufferers here. Most people say, no, I'm not going to make those flavonoids available to you. And all saw the same evidence. Most people said no, some people said yes. Why the difference? Well, we'll come to that. Well, maybe I'll suggest. The difference is different values and preferences. Most people say, oh, unless we have at least moderate, if not high quality evidence, we shouldn't be using it. The other people say, well, look, there may be only low quality evidence, but the evidence that there is suggests benefit. Let's give it a chance for the poor hemorrhoid sufferers. So we're putting a different value on the evidence. Some people want high quality evidence before they're going to recommend. Some say, no, if it looks like it might work, let's give people a chance to use it. Whether you said high, whether you said in favor or against, do you think this should be a strong recommendation or a weak recommendation? Have we got yes? We have a poll. Who thinks the recommended, whether you said yes or no, who thinks it should be a strong and who thinks it should be a weak? And so far, most are coming down on the side of weak. And that's what GRADE would actually suggest. GRADE would say, seldom, if ever, when there's only low quality evidence, should we be making strong recommendations, because we are not sure. So unless you insist on high quality evidence before you recommend at all, it's going to be a weak recommendation, because some patients might say, okay, I know it's only low quality evidence, but it might help. I would like to try it. So when there's only low quality evidence, we usually make conditional recommendations. Okay, in summary then, what have I tried to tell you? Clinicians and policymakers need summaries. They need summaries that include the quality of the evidence, and they need, when people make recommendations, they need to know the strength of the recommendation. GRADE provides explicit guidance for making the decisions about quality of the evidence and moving from evidence, summarizing the evidence in summary of findings tables, and moving from evidence to recommendations. GRADE is as simple as possible. It's transparent, it's systematic, and increasingly wide adoption. So thank you very much for listening. Thank you very much for participating in the polls. And if there are any final questions or comments from your group, Susanna, I'm ready to take the questions and comments.
Thank you so much, Gordon. Se vocês têm alguma pergunta para fazer adicional ao Gordon? We have one question, Gordon. Just a second.
Yes, Doctor. Just a brief question regarding agreement among examiners. Are there studies about kappa?
Yes, there is one study that looked at the agreement in rating certainty or quality of evidence, and it was not wonderful. It was fortunately not terrible. It was kind of in the middle. So again, the merit of GRADE is not that we're always going to agree, but that we have explicit and transparent criteria that we can all use. And if we disagree, we have a framework for discussing our disagreement and finding out why we disagree.
Yes, perfect. Thank you.
Alguma outra pergunta, gente? Tá todo mundo morrendo de fome. Gordon, I guess we have no other question here.
Okay, well, again, thank you very much, Susanna, for inviting me. It's been a pleasure to talk to you. And thank you for everyone who participated and who participated in the polls and answering some of the questions. So have a good rest of the conference. Bye for now.
Thank you so much, Gordon.
Okay,
Bye.
thank you.